Hi everyone, thanks for listening to my presentations. Thanks for coming to my channel. Yes, sickle cell disease part 2. Before you can enjoy this part 2, please kindly check out sickle cell disease part 1 that I've posted already on my channel. Then let's go. The epidemiology is essentially that it is highest amongst Africans and is found among African Americans in the United States. The Indians are not left out, particularly central India. The Middle Easterners are not out. The Caribbean islands are experiencing it, and immigration has brought it to the Western world, that is Europe and the like. So we can just say simply that sickle cell disease is now found worldwide. And you know what? Mutation to resist malaria is the fundamental pathological problem here. And if you have listened to my pathogenesis, you will understand better. Cure. Yeah, I need to be careful here. There is no cure per se up to today, but there are a lot of experimental processes going on, still at experimental stage, because it is not what has been worldwide known and is not practiced worldwide. So only few selected centers in some highly sophisticated centers in the world that are practicing this for now. And I think from the review that I got, maybe in 1 or 2 centers worldwide for now. I think one in United States. They practice hematopoietic stem cell transplantation and of course gene therapy. Like I said, this is still a speculative kind of stuff and is still at the experimental stage. It's not yet known worldwide. There's a great help with hydroxyurea that will be able to stimulate the production of hemoglobin F. And with the production of hemoglobin F, there will be a reduction in the symptoms of sickle cell disease. Again, this is not what is known worldwide, and I have put it here that might be in future there will be cure, but as of today there's no cure yet. It's still a genetic problem. Before we go into the symptoms fully, we need to be able to say by mere looking, that is physical examination, not even bringing the patient into the clinic and checking head to toe, but just mere looking, you should be able to project that this individual seems to be having sickle cell anemia. Okay? The habitus, sickle cell habitus. Most will appear slender, tall, with narrow shoulders, narrow hips, unusual head with busting frontal part, abnormal dentition, short neck, a bit kyphotic, long and thin arms and legs, short trunk, hoop-chested, hands that will be like spider hands, genital hypoplasia or atrophy, high-pitched voice, hypotrichosis, protruding abdomen from splenomegaly before they go into infarction, pigeon chest, impaired growth in children, and delayed puberty, poor nutritional status, particularly those from the very poor families, busting frontal lobes, swollen fingers and toes called dactylitis, sometimes associated with pain. Vaso-occlusive crisis is one of the major symptoms, and of course, crisis or sickle cell disease. And that will come with pain, ischemia of the bones, ischemia of the liver, ischemia of the kidneys, ischemia of the lungs, ischemia of the intestine, and ischemia of blood supply to the heart, and so on and so forth. And you know where that has come from, right? Because the shape of the red blood cell has become sickled, and while passing through blood vessels, they then tend to clog. When they clog, they obstruct the flow of blood to the target organ meant to be supplied, and that organ will become ischemic. If it is for a long time, can even become infected. That is why they have pain. Pain in joints, pain everywhere. And that is the account of which many people will present with at the clinics or hospitals. And the main reason why they will seek medical attention most of the time. Dactylitis, that is pain and swelling of the hands and feet. That will be the first manifestation of sickle cell disease in children as young as 5 to 6 months old. There's what we call splenic infarction in children. That is childhood splenic infarction, and that will lead to increased pneumococcal infection, and of course, acute chest syndrome. Anemia, for obvious reasons, when the blood has, particularly the red blood cell, when the red blood cells have changed shape to sickle forms, and they are now easily fragmented, then there's anemia from hemolysis, and also jaundice from hemolysis, and also gallstones are found. Priapism, particularly in males, of course, needless to say, you're not going to find that in girls, right? Don't mind me. Delayed growth in children, delayed sexual maturation, and pulmonary hypertension, particularly in those with acute chest syndrome. Dependent or leg ulcers, I'll talk about that more later on. And fever from everything, from infection, dehydration, and so on. Also rheumatism from the same occlusive problem causing ischemia and affecting the joints and the entire parts of the body. Heart failure from, of course, anemia, and the same with renal failure. And pneumonia because splenic infarction will lead to easy susceptibility to pneumococcal infection, and particularly acute chest syndrome. And as a matter of fact, majority that would die because of sickle cell disease would die secondary to pneumonia. Osteomyelitis, here is a big point, and I want you to pause here. Osteomyelitis could occur in anybody, and in the general population is going to be caused by Staphylococcus aureus, mostly. But there is a difference here. In sickle cell disease patients, they can have osteomyelitis like the general population, but mostly caused by salmonella. So salmonella will cause osteomyelitis in sickle cell disease patients in multiple times compared to Staphylococcus aureus. It's not that Staphylococcus aureus cannot cause osteomyelitis in sickle cell disease patients, or that salmonella cannot cause osteomyelitis in general population, but when the ratios are plotted, more sickle cell disease patients will have osteomyelitis caused by salmonella, and more other people in the general population will have osteomyelitis caused by Staphylococcus aureus. Leg ulcers. I'm not going to waste your time going over everything about wound here. First thing first, check the shoes and make sure that they are fitting well. You can have Doppler to detect whether we are dealing with deep vein thrombosis here. And of course, call for your D-dimer because you know the sequelae. If that is not handled, the next few minutes or hours may be battling with pulmonary embolism. Okay, mental impairment. Well, going through literature, I've read where it's been written, sickle cell disease patient will have mental retardation and so on and so forth. I disagree with this assertion. I disagree because my personal practice experience is not that I've seen hundreds and hundreds of sickle cell disease patients, but those that I've seen, 90% of them, they have interacted well, actually very brilliantly. In fact, I know the academic performance of some of them. They were very brilliant. Perhaps because those that I have handled had educated parents and they had all the privilege to attend schools, or those who wrote the literature put all those things together because they gathered their pieces of info among the poor people in poorest parts of the world, who, whether they have sickle cell disease or not, will not have any academic record, probably because they couldn't go to school, they don't have the fund, or many other reasons. So, from personal experience, I disagree that sickle cell disease will actually lead to mental impairment. For my own patients who had educated parents and who attended schools, they were very brilliant. Okay, what are the major types of sickle cell disease crisis? To medical students and nurses, you need to know this. Even if you are not going to remember anything, you have to remember this. The major types of sickle cell disease crisis are vaso-occlusive crisis. Many sickle cell disease patients present at clinics or hospitals for the first time because of what? Can you tell me the answer? Okay, you got it right. Because of pain. The pain is caused by ischemia as a result of blockage or clogging of blood to joints or organs. The sickle-shaped cells will become entangled or blocked and cause ischemia or infarction of the target organ meant to be supplied. I just said that some minutes ago, right? But you cannot overemphasize that. Children can have painful fingers and swollen toes as well, Cholelithiasis. Acute chest syndrome, I'll go to that later on. Priapism, joint pains, abdominal pains, headache, etc. are a few examples of vaso-occlusive crisis. What we're going to do here, I just going to talk about this briefly because I'll still talk about treatment separately, will be hydration. You hydrate generously. Give analgesics. The analgesics will vary from non-steroidal anti-inflammatory drugs to opioids. And of course, you can transfuse. Actually, they could tolerate low level of hematocrit. They don't decompensate so easily. But if the PCV is too low, then you transfuse. Okay, the second crisis I'm going to talk about is aplastic anemia / aplastic crisis. Somebody is asking me, what is the difference? Why are you calling one aplastic anemia and another one aplastic crisis? No qualms. We'll soon get out of it. Just give me 2 minutes. It's a very common crisis. Here, there will be persistent anemia. That's why in some cultures it's actually called sickle cell anemia. That's a major problem. But you know what? They have adapted. In other words, they are not decompensating. Even at PCV or hematocrit of 20%, under a situation where some other human beings will be fainting and so on, you will see sickle cell disease patient with 20% PCV playing soccer. They have fewer red blood cells, they will be pale, they feel tired, tachycardia when they are decompensating anyway, and decreased blood pressure. Aplastic crisis will lead to a very low hemoglobin with decreased red blood cells, but mark my words, there will be no signs of hemolysis. Aplastic crisis will occur with parvovirus B19 and other virus, different types, and of course, certain medications like chloramphenicol. Another major crisis is hyperhemolytic crisis. The sickle-shaped and brittle nature will subject the red blood cells to easy fragmentation. And this could be seen when you have peripheral blood film. When you cough that, you're going to see schizomes and target cells, all of them, fragmented cells. You're going to see them. Particularly when they're passing through tiny blood vessels. The red blood cells here have shorter lifespan. And of course, we are talking about hemolysis. So the bilirubin here will be unconjugated. And there will be high level of what? Iron released into the circulatory system. With the presence of high iron in the circulatory system, that will predispose more to increased infection. And with increased infection, there will be more probability of having fever. With more infection and fever, we're going to have more hemolysis, and with more hemolysis, we're going to have more iron, and with more iron, we're going to have more infection. So it's a vicious cycle that is going round and round and round, and it's unpleasant, and it's affecting these people every time on a daily basis. Sequestration crisis. You've heard the word before, sequestration. People have been sequestered, particularly the jurors. I mean, they are like caged. They are not allowed to talk. They're not allowed to move. They have been confined to a particular place. It's the same here. The blood is being pulled into the spleen and arrested there. So there will be increased splenic size, or better term in our language is splenomegaly. And with that, the abdomen will become distended or protruded and be painful, particularly if there is splenic infarction. There will be sudden drop in hematocrit and hemoglobin. Hello, there's possibility of sudden death here. That is the major cause of possible sudden death. Sequestration crisis. It's all about spleen and blood pulling in there. What you need to do first and fast is generous hydration. Transfusion is compulsory here, and that will help a great deal. Definitive treatment here will be splenectomy. As a matter of fact, some could have prophylactic splenectomy to prevent sequestration crisis. Because if there is sequestration crisis and the facilities are not available for generous hydration intravenously, With blood transfusion, death is at the door. There is a personal experience that I have of someone I knew about, let me see, about 8 years past. They were about traveling as a family across the Atlantic. And for the fear of the 2 cases that could run into sequestration crisis, prophylactic, elective splenectomy was done. Because that was safer. That would give the parents peace of mind that there won't be sequestration crisis along the journey, either while on air or while on ground. So prophylactic splenectomy was suggested. The family welcomed it and was done on the 2 children. It's a real life story. Not my patients, but I'm familiar with the family concern. Acute chest syndrome. That is the major cause of death in sickle cell disease patients. You know, I've just mentioned pneumonia the other time, right? Okay, just like pulmonary embolism, that's the way it's going to present. The sickle cells will block pulmonary artery and other tiny arteries in the lungs. Not going to block the major pulmonary artery most of the time, except when it's massive, but other tiny arteries will be blocked. There will be ischemia of the affected parts with possible infarction, and that will be associated with acute chest pain. So there will be fever, cough, acute respiratory distress syndrome. Ladies and gentlemen, this is always sudden. The sudden can lead to acute respiratory failure and death. And with that, I've come to the end of part 2 of my presentation when it comes to sickle cell disease. I'll be moving to part 3 very soon, and that will be all about treatment. We'll talk about treatment, and the last segment will be on prevention. So kindly subscribe to my channel so that you can get all these presentations immediately they are published. Thank you.